This is Morton Kern. I'm an interventional cardiologist in California here at the Long Beach VA, and I'm with a distinguished panel of experts, which I'll introduce in just a moment. And we're proceeding to participate and have this JSCAI Conversations in Interventional Cardiology, highlighting a very unique case on coronary function testing, seeking answers for refractory chest pain by Dr. Connor Tice at the University of Washington in Seattle. Now, I just want to introduce our panel. I just told you who I am. And we have Connor Tice. He's a cardiology fellow in the Division of Cardiology at the Department of Medicine and Cardiology at the University of Washington in Seattle. And Dr. John Blair, he's an associate professor of clinical practice, again at the same institution, and Dr. Larry Dean, JSCAI section editor of Pearls in Hemodynamics, a professor emeritus of medicine and University of Washington School of Medicine, Seattle. So we got a very Washington, Seattle-centric group here today, and I'm just going to start right in by asking Dr. Tice if he would take us through this case, and we'll talk about it as we go. So, Dr. Tice, the floor is yours.
Well, thank you so much for having us. This is a case that I think many of us encounter similar presentations with patients that seemingly have refractory chest pain despite multiple attempts at initial evaluation. So this patient first came to the attention of cardiology care about a decade prior to when we were involved in the case when he presented with a STEMI. He had an index PCI to his circumflex as well as the first diag. Over about an 11 to 12 month period, he still had some symptoms, and eventually, only a year after his index presentation, underwent a 2-vessel cabbage with a lima to his first diag and a vein graft to his OM system. Over the following decade, he had episodic stable angina that had multiple evaluations about every other year or so, including both functional testing and repeat angiograms that really showed no interval change in the degree of obstructive disease, but ongoing symptoms. He was on broad anti-anginal therapy with calcium channel blockers, nitrates, and beta blockers, and still was having episodic limiting angina. And then, as I said, about a decade after that index presentation, he came to our care where he came back through the ED with worsening chest pain, was thought to have unstable angina, and went for coronary angiogram. He had a new obstructive lesion in his PDA where he received 1 stent. Upon discharge from the hospital, he thought that he was feeling much better with resolved chest pain. However, that was short-lived, and he came back in for a clinical evaluation only a week later with ongoing angina. These are two shots from his angiogram that when he came in for his PDA intervention, the caudal and cranial shots that show that he still has disease significantly in his circ system. We can see in that first shot where his OM appears to be down. This is a segment that is grafted and had a patent graft, but this is one change that had happened from an angiogram about 2 years prior, where the degree of ISR in his circ to OM stent had progressed, but then he had preserved flow through his graft with retrograde filling of that entire OM. And then in his LAD, he has a noticeable bridge in the mid-LAD, but otherwise non-obstructive disease. And we'll take you through some of the evaluation that we will do later on.
So just a quick comment. So he has no lima graft, right? He did not need one. He didn't get one. Just
He did.
diagonal? and a mark.
It was a Lima, with the touchdown in the proximal first diag.
Oh, okay.
So, I'm going to walk you through what our approach is for a patient for broad spectrum coronary function testing. And, when a patient like this who's had a recent intervention comes back, really keeping a broad differential is one of the key takeaways that we're going to try to take away from this case. And starting with a repeat coronary angiogram, in a patient who had a fresh stent, there's a variety of things that could explain why he had interval resolution of pain and then a week later had recurrent symptoms. So repeating a coronary angiogram was one of the first things, just to make sure that all his degree of obstructive disease and his prior recently placed stent were all patent. But then in our workflow to kind of evaluate for alternative causes of recurrent chest pain is what I've tried to lay out here in this graphic. And so starting with baseline hemodynamics, he had what we think is a non-obstructive disease in especially in his LAD system. But actually using an objective measure and doing RFR or IFR testing of that vessel to make sure that we are truly assessing non-obstructive disease that is not hemodynamically significant. And once we've made sure that all potential intermediate lesions are truly non-obstructive and non-hemodynamic, then we proceed with coronary function testing, including spasm testing, as well as coronary microvascular testing, and potentially a bridge assessment as well. And with our spasm testing, with a pressure wire, we'll explain how we approach this in the next slide, but starting with low dose acetylcholine and test dose, and then up to 40, and then giving high dose 100 micrograms, looking for epicardial spasm. And then after washout and reversal with nitroglycerin, going on to the microvascular testing under hyperemic conditions with adenosine and looking at his IMR and CFR. And then after spasm and microvascular testing, if there's concern for functional impacts of bridge, that we can both do an assessment with intravascular ultrasound, as well as seeing what the stress hemodynamics are of a bridge with dobutamine. So the first shot is before his test dose was given, just to confirm, and we'll talk about this here in a second. As you can see, we have a wire down, which is something that not all centers do, and is something that we do. And so after not seeing significant spasm with the initial shots, no wire spasm, and then as he's progressed from 20 and 40 and then 100 micrograms of acetylcholine, he has near complete spasm of his LAD, which you can see in that second shot. And what we do in our lab is we leave that pressure wire down that had been used previously doing his RFR testing, and do an assessment of a distal versus the aortic pressure, and using some of the principles that we know from IFR or RFR testing, which this is, there is no validated cutoffs. That is why we're not calling it that, but showing that there is a hemodynamic significance to his spasm as his PDPA drops to 0.76. And you can see the graphic there as well. And so he has significant epicardial spasm. That was a new diagnosis for this gentleman.
So let's just pause for just a second. I think the whole field of acetylcholine endothelial function testing is fascinating. It's been around for a long time. The unique aspect of this particular test is that you've done it with a pressure wire. And somebody's going to ask, did this pressure wire information make any difference? That is, angiographically, you see diffuse spasm. It's really not a borderline call, it's diffuse. But someone would also say that, acetylcholine can, at this dose, can induce spasm in a lot of people who have abnormal endothelial function. So how do we reconcile this? What added value did you bring by putting a pressure wire in?
Yeah, I'd say at first, and after a brief comment, toss it to Dr. Blair as well, that I think that when the spectrum of spasm, and we have definitions in the field that talk about microvascular spasm, where you might have only ECG changes or chest pain or some endothelial dysfunction. If you're having, some degree of spasm that's not up to 90%, and we feel that with the wire down and ensuring at our baseline that our metrics are similar to that initial non-hemodynamic RFR testing of the vessels of the LAD, that once we're administering acetylcholine and seeing a distinct change with that dose, then it is correlative to the intervention we just performed, which was giving that dose of acetylcholine. Dr. Blair, curious your thoughts on this as well.
Yeah, that's a great
So,
question, Dr. Kern, and there's
yeah.
no standard here, but the standard definition for spasm established by the Europeans is a 90% reduction in lumen diameter. And in a lot of cases, you may get less than 90%, but you get all the clinical manifestations of their presenting symptom. So this is an attempt to objectively measure the flow limitations that's induced by the spasm. And, as with your career and what you've shown us, Dr. Kern, with these intermediate lesions, we've in fixed obstructive disease, we've kind of applied this to spasm in trying to identify patients who may have less than 90% stenosis with acetylcholine, but we want to measure its hemodynamic effect on that vessel.
Yeah, I think this actually is a very good idea because, as you just stated, often you may get less than 90%, but more than 50% narrowing. It may be diffuse, and it actually may be focal in different spots, serial focal areas that are affected more than other areas. And so this would be a net result of a spastic artery. Obviously, there has to be some future work on this to put your correspondence of a pressure gradient like this to a clinical test for ischemia and all the other findings of spasm. The only issues remain for me is that I think I can induce this kind of diffuse narrowing in a lot of people without frank clinical vasospasm. They'll get physiologic narrowing. They may even get a pressure gradient, but it doesn't really correspond to their clinical presentation in some cases. But this is a very interesting and important technique. We can talk about it more as we go forward. So I'm going to advance our slide for our colleague here, young colleague, so we can complete it and have some discussion. There we go. Okay, Dr. Tice, you're back up.
Yeah. So then after spasm testing and reversal of any spasm with nitroglycerin, we proceed on to microvascular testing. So this is done first with getting some baseline thermodilution and then inducing hyperemia with adenosine and then repeating thermodilution. So other than FFR, we can also obtain coronary flow reserve and index of microvascular resistance in CFR and IMR. And these values that were obtained are essentially, there's no evidence of microvascular dysfunction in this patient. And so at this point in the test, after we've evaluated for any new obstructive disease, we've now established a diagnosis of epicardial vasospasm with no microvascular dysfunction.
So this is a wonderful graphic that provides a depiction of the coronary microvascular circulation in the absence of epicardial obstruction and tells us about the arrival times of flow at rest and arrival time of flow to a distal thermistor at adenosine-induced hyperemia. And what is unusual in this tracing, I think, is the very, very high CFR, right? So your graphics here are beautiful. These are excellent curves depicting an arrival time at rest of 0.8 second That's about average. Between 0.5 and 1 is a resting ratio that people get. And then at hyperemia, this is very rapid. So this arrival time, the gold curves, are very distinct and very fast. It's unusual to have coronary flow reserve of 7 in a guy who has significant a middle-aged man, post-bypass, risk factors, endothelial dysfunction, and now he has a hugely normal CFR. What do you make of this?
Yeah, it was something that we talked a bit about when we were putting the case together and did some dives of into the literature of what are ranges of normal. And you're right, in the typical this patient population, it is atypical to have that high of CFR. In younger, otherwise minimal risk factor patients, you can see elevated CFR that is not connected to any disease. So, I don't have a great answer. Dr. Blair, I'm not sure if you make anything else of that as well.
I just want to observe there is a disconnect here because the usual thought is that if you have epicardial disease, you probably also have microvascular disease of a similar type, specifically increased resistance in the microvasculature due to atherosclerotic disease that's diffused through the entire coronary tree. But here we're just not seeing that, and every once in a while we get a case like this. I don't know if it's an error in measurement. I don't think it is because these are pretty good curves, and if anything, the other thing that we check is there an epicardial lesion that is somehow explaining a low CFR? And here we even have an FFR, if you look at the upper right-hand corner, of 0.84. It's not ischemic, but there is reduction in pressure across that vessel. But even with that, we still have a super normal CFR. I don't,
Yeah.
I'm not smart enough to explain that, but maybe, what are your insights here, Dr. Kern, Dr. Dean?
Well, I think he's very, I mean, it is very unusual for this patient with all his stuff going on to have such a high flow. I think that his resting flow might be a little higher might be a little higher number than we expect, maybe a little slower. And the hyperemic flow is certainly very rapid. I don't have a good explanation. Uh,
Yeah,
Larry, I mean, if you have
yeah.
something going on,
I guess my explanation would be our bodies unfortunately don't read the textbooks. It is interesting, but
damn.
it is what
It's
it is, so to speak.
Yes, it's true. Well, so I think the concept of microvascular disease divided into its 3 different phenotypes is important. So you've sorted out this chest pain with non-obstructive arteries and not a single non-obstructive artery, in this case, the LAD, uh, not responsible to or not a function of his lesions. It's not a function of his CFR, so it is a function of his physiologic narrowing in response to acetylcholine that you showed us. And it'll be interesting to see in his clinical world, as you've done, whether those changes correspond to any other objective evidence of ischemia, or is it just a symptomatic finding? Now, symptoms do account for a lot, but it would be nice to know if he really had some measure of ischemia with those things. But high flow should give him a good protective long-term event rate if that artery doesn't get worse. Spasm was got its own controlling mechanism. Okay, let's come in here to a summary slide
Yeah.
and see what we
And
do.
And so with our patient, that we've diagnosed now, isolated epicardial vasospasm, he has no fixed coronary musculovascular dysfunction. In terms of options for therapy, for spasm, we know there's great data for both calcium channel blockers as well as long-acting nitrates. There's also data for the beta blocker nebivolol that has properties that work through the nitric oxide pathway that also help with spasm, given that we don't traditionally reflex to beta blockers for spasm patients, but nebivolol gives an alternate pathway that has good data with that. Given that our patient was already on a calcium channel blocker for blood pressure control and was well controlled. We opted in him to add nebivolol for him. And I think one of the bottom two aspects of this graft, I think, are probably the most important for a patient like this. And noting that they are complex patients that may have multiple competing etiologies that are contributing to their clinical presentation. So we are implementing a trial of spasm therapy and seeing if that changes the narrative of a gentleman that has had multiple presentations for what had been just attributed to obstructive coronary disease, and seeing if it makes a difference, and then being humble to the fact that we may need to come back if there are recurrent symptoms and address some of those other potential aspects. We know that his circ has a stent that was originally placed, has had some interval change, and now is only getting retrograde flow through that graft. While we think that the distal flow is preserved given the graft patency, it is a change over the last several years. As well as we know that he has a myocardial LAD bridge. Normally, we proceed to bridge testing. In this patient, after his spasm testing and then his microvascular testing, he was having some ongoing chest pain that we opted to not proceed with that testing at the same time as his other testing, which we often do, but given his clinical situation, we decided to get him off the table. But it's something that if he had recurrent symptoms that we could bring him back for and more thoroughly interrogate his bridge. Thankfully, after his trial of nebivolol, clinically, he's actually been doing better now with multiple months of data since this presentation.
I'm gonna interrupt you. This is so good. I think this case really has a lot to talk about. Now, let me just take a quick shot. What is fixed microvascular disease? That's a term I haven't heard applied.
So that was just back to his microvascular testing that we went through on the previous graphic, that he had normal CFR, normal IMR, that his microvascular function was preserved.
Okay, so I just curious how you got to that term fixed. That would imply that there is variability, and
Yeah, I could jump in. I could jump in
Okay.
here.
Okay.
I guess we're trying to differentiate between the dynamic process that you can get with acetylcholine versus fixed, which we think of as fixed resistance that we can elicit when we give adenosine. Does that make sense?
So it makes perfect sense, but those are two different features of coronary microvascular disease, right? So epicardial vasomotion and microvascular responsiveness are separated, and you could more distinctly describe that in a different term. It's a minor point, but I hadn't heard it applied to CMD. I guess this is the whole bag of CMD subtypes. Right. Okay, so.
How would you yeah, I mean, this is just kind of how we've come about writing these in our reports to convey the information properly, but since as you pointed out, maybe that's confusing. How would you
I would just say exactly what you found, that there is evidence of epicardial vasomotion, vasospasm, and that the coronary microvascular circulation is normal. And leave it at that. So this is a very wonderful case. Now, second thing I want to just highlight is you selected nebivolol as your beta blocker in a patient with vasospasm. I'd been kind of exposed to the beta blocker story from day one back in the 80s, where Nashville
day one,
had,
come on.
Oh man, come on, I'm that old. Rosemary Robertson was the one who said that beta blockers were bad for spasm, leaving unopposed alpha. And, one of my first papers was about cold pressure testing and beta blockers making it worse. But it didn't, vasospasm kind of went away when Masarai moved from Rome to London. Anyway, nebivolol. Tell me about your selection of nebivolol just briefly, and then we'll wrap it up because I want to cover the bridge assessment. That's really interesting as well.
Yeah. So nebivolol, often labeled like a new generation, third generation beta blocker that has some other pathways than many of the other beta blockers that we use in general cardiology practice, that it has mechanisms that via the nitric oxide pathway can actually help with vasodilation. And so they've looked at this directly in spasm and looking at calcium channel blockers versus nebivolol. And it has pretty good data in clinical responsiveness of less clinical angina for patients. And so that's why when patients are maybe on an alternative agent such as amlodipine, and we're thinking, 9-hydropyridine versus dihydropyridine calcium channel blockers, and they're maybe well controlled on their amlodipine for blood pressure, we have an alternative agent that we could potentially add using different pathways to see if there's clinical response for spasm. And we've had some good clinical results and use it commonly, and haven't had, some of the historical response to beta blockers that had made us steer away from them for spasm patients with nebivolol.
Yeah. This is good. Dr. Blair, do you think that amlodipine is a good choice for vasospasm?
It's a great choice for hypertension, but probably not great for vasospasm because you cannot titrate it. It also doesn't have any rate controlling agents. In a lot of patients, they tend to have symptoms during periods of physical and emotional stress, and sometimes controlling that heart rate may help. And that's why the non-dihydropyridines can be helpful, like diltiazem and verapamil. But just overall, in this patient, he's been on, this is not his first rodeo, and he's been on everything.
Yeah.
So I take a pragmatic approach to treating these patients. We have to go through their medications, talk to the patient, see what's worked and what hasn't worked. And it seemed that no matter what calcium channel blocker he was on, he still had his clinical syndrome. So the other thing that the beta blockers can do is it can block the sympathetic output, which also seems to play some role in vasospasm. And with the nebivolol, which adds a little bit of nitric oxide, at least theoretically, we chose that to augment his already existing calcium channel blocker. So we netted him only one additional medication rather than rearranging everything and trying to reinvent the wheel. And that's just been my approach to medical therapy for patients, but other people may have other approaches.
No, I think this is excellent, and the proof is in his symptom relief, which I believe you reported. My last issue, because we've really we could probably go on for another 20 minutes in this case. I just want to talk to you briefly about myocardial bridge assessment. So, Larry, when you looked at that angiogram, what was your thinking about this bridge? Was there a significant importance to the narrowing that we saw?
We could talk about myocardial bridges for quite some time as well. It's certainly there, and then it becomes, what role is it playing? And I think the discussion we had earlier about looking at the physiology of those, I think is something that needs to be looked at. I'd also agree, though, this patient was having ongoing chest discomfort. You had a diagnosis, and why give the patient two diagnoses? We kind of always talk to do, you got one diagnosis, don't give them two diagnoses. So rather than going down the direction of the bridge assessment, that would be my thought about this.
I think this bridge is at the moment just an innocent bystander because it didn't seem to be highly compressive. That's just it, my view of that angiogram. And let me just ask Dr. Tice, in short, what would you do what will be the technique you use to assess a myocardial bridge as contributing to ischemia?
Yeah, and so with a pressure wire down, like we've done before, but getting our baseline hemodynamics, and then administering dobutamine infusion, and to see how their hemodynamics change under those stress conditions. And and to see if they become hemodynamically significant. And I'll just add one other aspect is that we know the association between bridge and spasm. And so while we think it's probably the innocent bystander, seeing them both together is something that we see commonly, and potentially treating the spasm that we know is associated with that bridge may be the thing that actually gives clinical relief versus the very complex and significantly invasive management of a bridge.
Excellent. Excellent. I'm going to just say I have some reservation about dobutamine in bridges because a very mild bridge, you can induce a narrowing, which may be beyond that which they get in normal life. And so there's some question about the finding, what it means in real clinical practice. But I think this is the way to do it. Would you use IVUS in imaging?
Yeah, sorry, absolutely. So being able to see the bridge depth, true lesion length, that's before we stress the patient, something that we routinely do.
In summary, give me your take home on this case. This is such a good case.
Yeah, I think this case is one that shows that patients with ongoing chronic chest pain are really complex. And there's often, we wish sometimes when we do an angiogram that it's a simple lesion that can be easily treated with a stent, and then we, can pat ourselves on the back and walk away, and we've healed that patient's symptoms. But in the real world, we all know that these patients are complex. They might have multiple competing etiologies for their chest pain. And I think having a systematic way to approach chest pain evaluations after that first attempt has led them back to us. And being able to go through an algorithm that you can put people in different buckets beyond just obstructive disease, trying to see if they have spasm, trying to see if they have microvascular dysfunction, initiating a trial of therapy, but being willing to come back to that differential and explore some of those other avenues to apply therapy to make them feel better.
Yeah, that's a good encapsulation. So, Larry, final thought?
Yep. Yeah, my final thought on this is a great example of what I would call the oculostenotic reflex. And what I mean by that is, we've been putting stents in people because we see lesions. And we got our hands slapped in the past around this, just casually doing it. However, this is the same problem. This patient's been undergone coronary angiography multiple times over the years, and we didn't find anything. Or if we found something, we fixed what we found. But we didn't do this until now. So the important part of this whole case report, my thought is we need to start thinking about this more frequently. We need to have our colleagues start doing this more frequently, because it's not just about lesions that we can see. So again, that would be my final comment.
Excellent. Dr. Blair, short comment?
Yeah, I agree with all those sentiments. I mean, our jobs as interventional cardiologists, when a patient comes to our table, is like we have to be the final say in what's going on with a patient. I mean, for a lot of our non-invasive colleagues, they try to, there's such good non-invasive studies to try to sort out what's going on with a patient that that by the time they hit the table, they're looking to us for the final answer. And the answer is often not whether we can find something to stent, but what's causing their chest pain. And we can't answer that if we just look at it through the lens of stenting and things like that. And we have to take a broader approach, just like everybody has highlighted here.
Yes, I agree. I think that the assessment of the microvascular circulation in patients who have chest pain and also significant coronary artery disease, particularly after multiple stenting bypass, presents a real challenge because we know that endothelial dysfunction is likely a contributor. It's there, whether it's vasospasm invoking or not. I think that clinical follow-up of this man will be fascinating. And I want to say thank you for sending the case to JSCAI. Thanks for joining us on our JSCAI Conversations in Interventional Cardiology. And I look forward to seeing more of this going forward.